Hi, my name is Brooke. I'm a pediatric oncology nurse practitioner, and today I'd like to talk to you about fever in the setting of neutropenia in the pediatric oncology population and the possible progression to septic shock. Let's start with some basic definitions. Fever is defined as any single temperature greater than or equal to 38.3 Celsius once, or a temperature of 38 that is sustained for 1 hour or occurs more than once in a 12-hour period. Severe neutropenia is defined as an absolute neutrophil count below 500. So how do we figure that out? If we look at our patient's total white blood cell count and we multiply the percentage of segmented and banded neutrophils, we can easily come up with a calculation for our patient's ANC. Not only is it important for nurses to figure out what their patient's ANC is, but it's important for them to understand where their patient is in their cycle. Is their absolute neutrophil count dropping? Is it increasing? Where are they from the time that they receive their chemotherapy? The patient's nadir, which is when their white blood cell count is at its lowest, typically occurs 7 to 10 days from the first day that they received chemotherapy. So for example, if you have a patient with Ewing sarcoma who's receiving 5 days of ifosfamide and etoposide, and they get discharged from the hospital on day 5, within 2 to 3 days, that patient's white blood cell count, along with their other counts, are going to start dropping. It's important to understand when you first receive that call to the clinic or to the emergency room to understand just where your patient is in their cycle. This can be a true oncologic emergency when a neutropenic patient presents with a fever, and a child that is relatively well appearing can become very sick very quickly. So being prepared for that patient to arrive in the clinic or direct admit to an inpatient unit or to an emergency room is super important. It is a team approach, so oftentimes having several nurses and the provider available from the time the patient walks in the door is important. The first thing the nurse needs to do is do a quick assessment of their patient and vital signs. They need to access the central venous access device as quickly and safely as possible and anticipate drawing blood cultures from each lumen of the central venous access device, in addition to a CBC with differential and an extra tube that can be used for a type-in screen in case the patient needs blood product support. We used to draw peripheral blood cultures, but that is now considered a weak recommendation from the Children's Oncology Group, and it is not often done anymore. The nurses should anticipate that the patient will not only need to have maintenance IV fluids, but they might need to have, or should possibly have, a bolus of IV fluids. This is typically 20 mL per kilogram of body weight of normal saline or lactated ringers. The way that bolus is given is in 2 different ways. One is that you can hang the bolus on an IV infusion pump and run it at the maximum rate, and the other way is the push-pull method, where you use a straight tubing, a bag of fluid, a 3-way stopcock, and a 60 mL syringe, and the nurse can actually draw the fluid out of the IV fluid bag and push that fluid right into the patient. One might ask, well, why would I need to do all that when I can just run it on the pump? Well, it's a matter of time. We always want to have our IV fluid bolus into the patient within 30 minutes of arriving to the clinic. We want to have the antibiotics administered within 60 minutes. If I am using a 1 liter normal saline bag to give a 1 liter bolus to a patient, I can manually push that 1 liter in about 20 minutes or less. If I run it on the infusion pump, it's going to take an hour. So talking about antibiotics, the provider is going to order a broad spectrum monotherapy drug that covers Pseudomonas like Zosyn or Cefepime. If the patient warrants, they might add a 2nd gram-negative agent if the patient is potentially clinically unstable, something like gentamicin, or they might add an additional gram-positive antibiotic or something that covers a gram-positive bacteria like vancomycin. They might also decide, based on the patient's clinical exam, to add better anaerobic coverage or some sort of fungal coverage. Certain patients are a higher risk for developing fungal infections. Those patients are those with AML, high-risk ALL, relapsed ALL, patients undergoing a hematopoietic stem cell transplantation, those with prolonged neutropenia, and patients that are on steroids. Keep in mind that patients that are on steroids might have a harder time showing signs of infection. And patients with prolonged neutropenia means that they're going to have a white blood cell count of less than 0.1 with no neutrophils for a longer period of time, making them that much more susceptible to having an infection. A patient will stay in the hospital receiving their antibiotics and maintenance IV fluids, and it's important that the nurses and the medical team monitor the blood culture results and change them according to whether or not the patient grows any bacterial bugs or fungal bugs. Discharge criteria for these patients is usually based on 3 things. They need to have a negative blood culture for at least 48 hours. They have to be afebrile for 24 hours, and they have to have some counts of or some evidence of increasing blood counts or bone marrow recovery so that we know that they're going to go home and be safe. Nurses play a big role in being able to monitor for changes in their patients, and we're going to talk a little bit about things that they can look for. Something like endotoxin release is one thing. Moving on to septic shock. So septic shock occurs in severe sepsis or severe infection where organs fail to receive a sufficient amount of oxygen. On a cellular level, there's a lack of oxygen, leading to inadequate perfusion and hypotension or a drop in blood pressure. This is a life-threatening condition. We already talked about the treatment for that in the sense that we talked about IV fluid and boluses, but that's not the only thing. Sometimes in septic shock, we might have to escalate our care and give vasopressors in like a pediatric intensive care setting, or give volume expanders, red blood cell support, or steroids. We talked a little bit about endotoxins. So what are endotoxins? Endotoxins are toxins that are found inside the bacterial cell wall of a gram-negative bacteria. What happens is that we give the antibiotics. That leads to cell death and the release of these endotoxins, and you can have an overwhelming immune response in your patient, and your patient can actually decompensate quickly. I can't tell you how many times I've seen a patient come in with fever in the setting of neutropenia. They look okay, their vitals are stable, the nurse gives the first dose of antibiotics, and everybody walks away. And that's when the patient actually becomes sick because of this endotoxin release. So it's really important for nurses and residents to be cognizant of the fact that it could be after the first dose of antibiotics that are given that the patient actually becomes really sick. Talking about the signs and symptoms of septic shock include tachycardia, tachypnea, hypothermia in addition to fever, cool or mottled extremities, decreased or absent pulses, a decreased or changed level of consciousness, hypotension or a wide pulse pressure, and sometimes vomiting. It's so important to understand all of these things that could happen to your patient. It's important for nurses to not only be prepared, but to monitor for a change in their patient's exam or vital signs, to monitor for possible positive blood culture results and report those to the providers. But they really have to understand the pathophysiology of septic shock and what can happen during this infectious process so that they can in turn teach their patients and their families. Thank you for joining me today.